Assalamualaikum and hi everyone. I hope this find you in a good condition. My name is Marina and I'm going to do a presentation on the lateral scapular projection. We are going to do a lateral view projection, therefore the radiographic outcome should look like this. So, we start off with the first criteria in evaluating a radiographic image, which is the projection and the positioning. Projection. This is a scapular projection because the anatomic structure includes the glenoid cavity, acromion, scapular body, and the inferior angle. This is a lateral projection because there is a superimposition of the lateral and vertebral borders of the scapula. The scapular body and thoracic cavity does not superimpose with each other, and the body of scapula is clearly demonstrated. So let's check on this radiograph. This is the radiograph of the lateral projection of the scapula. I say so because the glenoid cavity, acromion, scapular body and the inferior angle is in sign. Scapular body and thoracic cavity does not superimpose with each other, and the bodies of the scapula is clearly demonstrated. Next, positioning. So for the positioning criteria, the criteria is vice versa between AP and PA. So before you checking the positioning criteria, you have to identify whether the patient was in PA or AP position. So you can see here, the AP position is like this. It's like the centering ray, the beam starts from the lateral aspect of the patient and it exits like at the medial aspect of the patient, while for PA position, you can see like it starts from the medial aspect of the patient and it exits at the lateral aspect of the patient. So let's check the first positioning criteria, scapular obliquity. If the lateral border is superimposed by the thorax, the obliquity is insufficient. So this is the lateral border, this is the vertebral border. So how to differentiate between lateral and vertebral border? The lateral border is thicker than the vertebral border. So the lateral border has two bony cortical outline, while the vertebral border only has one bony cortical outline. If the vertebral border is superimposed with the thorax, the obliquity is excessive. As you can see here, one bony cortical outline, which indicate it is the vertebral border. Take note, this is for patient in AP position. For patient in PA is vice versa. For example, if the lateral border is superimposed by the thorax, the obliquity is excessive for PA patient. Second, upper mid-coronal plane tilting. Patient leaning towards IR or interiorly. Clavicle is seen inferior to superior scapular angle. You can see here, this is the superior scapular angle and this is the clavicle. If the patient leaning away from IR or posteriorly, the clavicle is seen superior to the superior scapular angle. This is the clavicle and this is the superior scapular angle. Take note, this is patient is in PA positioning. For AP, this criteria is vice versa. For example, if the patient leaning towards the IR or anteriorly, the clavicle is seen superior to the superior scapular angle. It should look like this. Additional information. How to differentiate between lateral scapula and PA oblique shoulder or the scapula Y lateral projection. So let's see the lateral scapula first. Affected arm is placed on the opposite side of shoulder if patient is in erect position or elevated above 90-degree angle if the patient is in recumbent position. But in scapula Y lateral, the affected arm down. Next, for lateral scapula, centering ray is at the mid-vertebral border of the scapula, while for scapula Y lateral, the centering ray is on the scapulohumeral joint. Let's check this radiograph. So, the positioning for this projection is wrong. This is because the lateral and vertebral border of the scapula is demonstrated without superimposition. The vertebral border of the scapula is demonstrated closer to the thoracic cavity. The clavicle is seen superior to the superior scapular angle Thus, the patient is tilted towards IR or posteriorly. To improve this, rotate patient's body internally to increase the degree of patient's obliquity. Second, tilt patient anteriorly until the mid-coronal plane is perpendicular to the image receptor. Second criteria in evaluating a radiographic image is alignment. First, alignment between patient and image receptor. The alignment is incorrect because the superior is longer than the inferior. The right side is longer than the left side. Second, patient and collimation. It cannot be determined because there is no four borders of collimation. Third, alignment between image receptor and collimation. It also cannot be determined because there is no four borders of collimation. Centering ray. The centering ray for this radiograph cannot be determined because there is no four borders of collimation. The standard centering ray for this projection is at the mid-vertebra of the scapula border. Third criteria, collimation. At the superior border, the structures should include acromion, glenoid cavity, and clavicle. At the inferior border, it should include inferior angle and the scapular body. At the lateral border, the structures should include acromion, lateral border, and the glenoid cavity. Fourth criteria, exposure factor. Contrast. The bony cortical outline for the thin structure, which is the coracoid process, can be seen. The bony cortical outline for the thick structure, which is the body of the scapula, can be seen. Therefore, the KVP used is adequate. Density. Bony trabecular pattern of the thin structure, which is the coracoid process, can be seen. The bony trabecular pattern for the thick structure, which is the body of the scapula, cannot be seen. Therefore, the MAS used costs underexposed to the thick structure. Thus, the MAS must be increased by 50%. Fifth criteria, marker. Take note, only plumbar marker are acceptable. There is evidence of an anatomic marker shown in the radiograph, correctly placed on the right side of the body and placed in the correct orientation, not superimposed with any regions of interest. Sixth criteria, aesthetic value. The cassette size used for this radiograph was 24 times 30 cm in lengthwise. There is no sign of internal artifact, but there is a sign of external artifact, which there is a marker scribble on the bottom left side of the film, but it doesn't superimpose with any region of interest. Last criteria, name. The patient's identification, date of examination, place of examination are not included in the radiograph. It can be put at the top left or top right corner of the film, as long as it doesn't superimpose with any regions of interest. For conclusion, this radiograph is rejected because there is no sign of identification of the patient were included in the radiograph. Second, the MAS used cost underexposed to the thick structure, which is the body of the scapula. If you have any question or if you want to do a further reading, please go check out the book and the website. That's all from me. Thank you.